Okay, hi everyone. This is part 2 of our lecture on chapter 6. So we talked about alcohol use disorder in part 1. Now we're going to continue on to talk about the rest of the substance use disorders that are outlined in this chapter. We'll start with tobacco use disorder. Okay? All right. So just a little bit overview. So it says it's characterized by persistent tobacco use, right? Obviously, also thinking about it as compulsive tobacco use and also physiologic dependence on tobacco. Okay. In general, if you think about those with tobacco use disorder, usually overall a poorer general health. Some statistics that are interesting here. Apparently, and again, this is dependent on when these studies were done, but about 42 million Americans continue to smoke, right? Even though we know how dangerous smoking is for your health. Also, again, I don't know when this study was pulled from, but vaping by middle and high school students has increased by 50%. I know now, I think that some of those numbers in terms of the percentage of high school and middle school students that are vaping, I feel like I've heard a statistic where those numbers have come down. Okay. Still an issue that, a new sort of health issue was definitely brought up when vaping was introduced. Okay, so in terms of, right, tobacco, what's tobacco? It's actually a leafy plant, right? And you can basically grind up those leaves and make cigarettes out of them. Now, at one point, when you talked about like smoking a cigarette, it was mostly tobacco, okay? Unfortunately, now that's not the case, okay? Now, what's the compound that's addictive in tobacco is nicotine, okay? I guess, though, there are studies that indicate that maybe nicotine's not the only addictive component of tobacco, okay? But we'll focus kind of here on nicotine a little bit. Like I said, cigarettes nowadays are actually composed of approximately 600 other ingredients, okay? And when you burn that cigarette, you actually can create more than 7,000 different chemicals, okay? So you're not really smoking tobacco, right? Pure natural tobacco in any sense. It's a whole bunch of chemicals that you're basically putting into your body or inhaling into your body. So I noted here table 6.4. So let's take a look at that. Just like I kind of did before, I'll pull up the e-text here and just take a look at that table. Okay. So let me just switch pages. Oh, I might have missed it actually. Yeah. Wait, let's see if it's there. It's probably at the bottom of this page. It's my fault. Yeah. So this is actually some chemicals that are found in tobacco smoke, right? So like I just said, once you burn that cigarette, it can form over 7,000 different chemicals. Okay. And some of them are listed here, and it's kind of nasty if you think about it, right? Benzene, carbon monoxide. Okay. And it's kind of showing you other uses or where these come from. Acetone. Okay. Methanol, lead, nicotine, okay, so there's just some examples of these different chemicals that are released, okay, or are produced when that tobacco is burned. Not tobacco. I mean, it says tobacco smoke, but really this is cigarette smoke, right? This is a result of all these other chemicals that are added to cigarettes nowadays, okay? If you were just smoking pure tobacco, I'm pretty sure this wouldn't be the case, okay? So like I said, this is really a result. Sorry about that. I don't know why that did that. This is a result of all of these extra chemicals that are added. Okay. So let's move on here and go back to the another thing here. Kind of notes always sort of in this book, right? They'll kind of put these little inserts in the textbook where it talks about the special populations, right? So it's just making a note here that just like we said with alcohol, right? Adolescent brains are much more vulnerable to the effects of, right, tobacco use, and particularly all these chemicals that are produced than adults. Why? Because their brain is still developing. Okay. Now, if we go back, let's go back. Sorry, if I can, please, computer. Let's go back to our PowerPoint. Okay. Alrighty. Oh, duh. I'm hitting the wrong thing. Sorry about that, guys. Okay. So, one of the things that you want to kind of think about, I guess, in terms of it's mentioning here peak plasma concentration of nicotine, meaning the levels of nicotine that are in your blood depends on the method of delivery. And so inhalation is actually the fastest way to get to this sort of peak plasma concentration of nicotine that you see, or that's necessary to exhibit or to elicit the effects that nicotine is going to have on the body. Okay. So once it's inhaled, it gets rapidly absorbed into the pulmonary venous circulation, and then it makes its way to the brain. Okay. And so it can diffuse into the brain tissue, and then it will bind to its receptor, right? Particularly, it's called a nicotinic cholinergic receptor. Okay. And the reason why it's called nicotinic is because nicotine binds to it. Located in the mesolimbic system, right? So remember we talked about the mesolimbic system in the beginning, and that's, this reward system, okay? What kind of, we kind of think, I guess, of sort of short-term effects of nicotine, right? Increases performance on tasks that require rapid information processing, because it activates brain areas that are involved in visual attention and also and or motor activation in other brain areas as well, that you can kind of think of is sort of increasing concentration, right, and focus. However, right, long-term, and obviously nicotine has, or cigarette use, right, or tobacco use has many other adverse health effects, right? And over time, you can and will develop tolerance. Okay, so again, what does it mean when we say developing tolerance? It's the idea that you're going to have to take more of that drug to basically get the same effect that you were getting before, or the effect that you're looking for, right? So you may start off by smoking 1 or 2 cigarettes a day, and then quickly you might be up to smoking a pack of cigarettes a day because of this tolerance, okay? And we see tolerance in all of these substances that we're talking about in this chapter. Okay. Also, the effects of nicotine do extend outside the central nervous system because there are cholinergic receptors in the periphery. Okay, and so there it can, and so therefore it can act as both a stimulant and a sedative. So you can kind of, it has a sort of a dual role. If you think about the stimulant effect, that actually is partly due to the release of epinephrine. So remember we talked about increase in sympathetic activity, right? When the stress response is activated. So it's going to interact with some of the receptors kind of as part of the sympathetic nervous system, and can lead to these, increase in sympathetic activity. Okay, so that's when suggesting it's a stimulant. So if we think about some of these, right, these stimulant type of effects, we can see some immediate physiological effects, right, like tachycardia, hypertension, right, increased respiration. Other signs that you may see during physical assessment, right, in somebody who has tobacco use disorder, or, smokes a lot of cigarettes, right, hoarse voice, stained nails and teeth, obviously also the presence of tobacco paraphernalia, but that's not really, I guess that's not a physical assessment of the person, but I guess it's something you would still, you could still potentially notice. In terms of signs of withdrawal, right? And again, most of these signs of withdrawal that we see, or that are listed here, are similar when you think about withdrawal from a lot of these substances that we're talking about. So irritability, frustration, anger, right? Anxiety, difficulty concentrating, increased appetite, right? These are all signs of withdrawal. Or if, you're trying to quit smoking, you may experience some of these signs as you sort of just stop smoking, and you kind of have to get past these withdrawal signs or these withdrawal symptoms, right, before you can really get over that habit, right? Okay, we also see some comorbidities with tobacco use disorder, right? So some kind of interesting, I guess, sort of statistics here. So it does say here that just in general, in people that are patients that have psychiatric conditions, there is an increased percentage of smokers, okay? If you look at severe mental illness like schizophrenia or bipolar disorder, there are studies that indicate that the percentage of smokers, or the smoking rates in those populations can be as high as 90%. Okay, so a lot of times you do see that patients who smoke may have some psychiatric condition, right? And then you can kind of think of them as using the cigarettes to sort of self-medicate. Also, you'll see decreased immunity. So, again, just like we've talked about many things, we've talked about stress affecting immunity. A lot of these substances can interfere or interact with the immune system and decrease function. Okay. Other associated diseases, and we'll talk about COPD when we talk about some pulmonary, specifically focus on pulmonary diseases. So we're not going to talk specifically about what happens in COPD now. Okay. It's something we'll talk about in a later chapter, but, COPD, cardiovascular disorders, and also cancers as well, right? Obviously the big one, lung cancer. In terms of diagnosis and treatment, okay, there are, smoking cessation aids, right? Like there's patches, like a nicotine patch. That's a nicotine replacement medication. There's other types of aids like gum that can, nicotine gum and things like that. Also behavioral therapy. You could also, there are, right, like the use of sort of smokeless tobacco as a way of getting you off cigarettes, but these have some, harmful effects as well, right? That they have some carcinogens that are present and they also pose a risk for cancer. Okay. All right. So moving off of tobacco use disorder and into our next use disorder, and this is cannabis use disorder. Okay. So cannabis is the third most commonly used drug in the United States. Okay, so marijuana is derived from the hemp plant. Okay, the main psychoactive chemical, as probably most of you guys already know, of marijuana is THC, right? Tetrahydrocannabinol. You can smoke it. You can also ingest it, right? In terms of kind of, this is just giving you an idea of, in terms of kind of the time it takes for it to be eliminated. So the total, for a single dose, right, to be eliminated from the body, a single dose of marijuana to be eliminated from the body, takes 30 days to be completely eliminated. So it stays around for a long time. Okay, in terms of THC, right, we said that that's the main psychoactive chemical, right? THC, that's what's going to initiate the psychoactive effects that marijuana has, okay? There are receptors in your body, cannabinoid receptors, right? CB1, CB2, and they're located throughout the body. So if you think about in the periphery, outside the central nervous system, they're actually located on immune cells. Within the central nervous system, you can see them, basal ganglia, right? We mentioned basal ganglia when we were talking about reward pathway early on, hippocampus, cerebellum, etc. There are other brain areas where you see expression of CB1 and CB2 as well, okay? So THC will bind to the receptors in these different brain areas, and that will be responsible for some of the effects that you see, okay? Also, though, there are endogenous cannabinoids. So just like, and we're going to talk about opioid drugs, I think that's our last topic to talk about, but there are also endogenous opioids, right? Like endorphins, and they bind to these receptors. So CB1 and CB2 have natural ligands, right? Have endogenous cannabinoids that function normally in the body. Okay, so they're not, the CB1 and CB2 receptors aren't there just for THC to bind. They're there because they play a role and they have other endogenous compounds that will bind to them. Okay. In general, again, like pretty much all of these substances that we're talking about, you're going to get an increase in dopamine release. Okay. So dopamine will be increased, but again, the action of THC is due to binding of these CB1 and CB2 receptors. And then I guess kind of think of as sort of an indirect increase in dopamine. Okay. So it says here results in impaired judgment, also increases risk-taking, okay, because there are CB1 and CB2 receptors in the prefrontal cortex, right? So prefrontal cortex, remember, is the brain region involved in decision-making, okay? So like I said, this is just listing a few brain areas. There are CB1 and CB2 receptors pretty much all over the brain, okay? In terms of immediate effects, right? If you think about immediate cognitive effects, right? Difficulty with thinking and problem solving, loss of motor coordination. If you think about immediate psychoactive effects, can be anxiety or paranoia, right? If you're talking about physiologic effects, tachycardia, dry mouth, okay? Now, if we're now going to talk more about prolonged effects, right? And we're going to talk about, cannabis use disorder. It's going to lead to disruptions in functioning, right? Meaning functioning in daily life. Again, tolerance. You're going to see tolerance develop just like all of these substances, okay? Also withdrawal. Some of the symptoms of withdrawal here: inability to sleep, right? Restlessness, anger, etc. Okay? All right, so let's, I guess, move on here. Now, remember before in part 1, I pulled up the NIH website where they talk a little bit, that was specifically for alcohol use disorder, right? But I showed you this DSM-5. So again, just remember, if you're curious and you really want to look at what the diagnostic criteria are for some of these substance use disorders, you can reference this DSM-5 to see what they are. So just giving you a little bit of an overview, right? So I'm not listing all of the symptoms here. So if you're going to talk about, again, these are different levels, right, of cannabis use disorder. So cannabis intoxication, right? 2 signs or symptoms within 2 hours of using cannabis. So this is right away, right? Increased appetite, dry mouth, tachycardia. If now you're going to talk about withdrawal, okay? Sorry. So I guess this isn't really different levels of cannabis use disorder. These are sort of different levels, I guess, of cannabis use in general. And then when you get down to cannabis use disorder, you're going to see that the symptoms are more serious, okay? So again, if you're talking about withdrawal, how do you determine if a patient is actually in withdrawal, cannabis withdrawal? You're going to look at these particular signs and symptoms that are listed, right? So this is saying over 1 week, things like irritability, anger, and depression, okay? Now, when we get to the level of cannabis use disorder, okay, there's significant impairment, right? Distress in multiple areas that are listed as sort of criteria in this DSM-5, development of tolerance, withdrawal over 12 months, persistent use of cannabis will negatively affect the individual's ability to work, right? Or I didn't mean to write or work, etc. I think I meant ability to go to work or go to school, etc. Right? So the idea is that it's gonna interfere with daily activities or daily responsibilities in some way. Okay? Treatment, cognitive behavioral therapy is an option. That's one of the sort of big main options out there. We talked about tobacco use where there's like cessation therapies, right? Like nicotine gum or some other types of aids that can help you with that nicotine patch. For cannabis use disorder, we don't have those types of therapies. Okay, so again, I'm just kind of summarizing here. Let me just take a look at the book real quick. I just want to see if they give a little bit more detail. I forget if that was one of the ones that gave a little more detail about some of those diagnostic criteria. So I'm not holding you guys accountable for memorizing diagnostic criteria, and that's why I'm not always putting it in there. So let's just see if there's a table here that I could just reference just to show you guys. Okay. Oh, here's a video. Let's play it and see if it actually plays.
Marijuana is a drug that is typically smoked. The smoke travels into the lungs and makes its way to the alveolus. Inside the alveolus, the smoke is processed, and the chemical in marijuana, known as THC, enters into the bloodstream. The chemical travels in the bloodstream through the heart and up into the brain. Marijuana affects various brain functions, including higher cognitive functions, body movement and coordination, the reward center, muscle movement and control, and memory.
All right, so hopefully you guys could see that. I just wanted to see what that was about. So it was a little slow, but I think it was kind of a nice overview. And yeah, there is no table that really details any more of those clinical manifestations or those diagnostic criteria that I was mentioning. So like I said, the reason why I mentioned this here where I say specific criteria in DSM-5 is that if you're interested and you want to look at more of those specific criteria, you can take a look. Okay? It's too much for me to include. This is long enough as it is. All right. So our next disorder that we're going to talk about is stimulant use disorder. So stimulants now. Okay. So in terms of overview, right? What's listed here are the most commonly abused stimulants. So amphetamines, and actually amphetamines are approved for treatment of narcolepsy and ADHD. Obviously, people take them even if they're not prescribed amphetamines. And what you'll see with amphetamines is an increased synaptic activity of dopamine and norepinephrine. Okay. Also, synthetic cathinones. These are amphetamine analogs, right? Or maybe you guys have heard of bath salts. And so when something is an analog, it's going to behave chemically similarly to amphetamines. Okay. But they're synthetic and they're pretty dangerous. Sometimes these analogs, though they sort of behave in a similar way, they have some of these weird adverse effects that you wouldn't see with amphetamines themselves. Methamphetamine readily crosses the blood-brain barrier. Okay, so if we talk about the blood-brain barrier, it's this sort of it's the idea that you have the bloodstream separated from the central nervous system, right? And it's made up of certain cell types like glial cells and also other endoepithelial cells. And basically it's a lot harder for drugs or difficult for certain drugs to get across that blood-brain barrier. Okay. Anyway, because it readily crosses that blood-brain barrier, it has a really quick onset of action. Okay. And again, what you see is an increase in dopamine, increase in norepinephrine, increase in serotonin, right? And obviously activation of this dopamine reward system. Okay. Another stimulant, cocaine. Cocaine is actually plant derived. Okay. What does cocaine do, or what's kind of a little bit into its mechanism of action? It will block reuptake of dopamine and norepinephrine, therefore increasing dopamine and norepinephrine levels, right? So it's going to have a sort of similar end result, but its mechanism is a little bit different. Initial effects, right? Euphoria, enhanced self-esteem, also initial kind of effects that you might see like in the clinical setting, right? Chest pain, palpitations, even seizures. Okay. So in terms of, stimulants, they can be synthetic, right? Like some of the ones we mentioned up here, the amphetamines and things like that, these cathinones, but they can be plant-based. So cocaine is an example of a plant-based stimulant. Okay. They can be inhaled. They can be taken orally. If we look at table 6.5, this is going to outline signs and symptoms of stimulus use disorder. So let's take a look at that table because I think that is worth taking a look at. I believe, it's here. I think. One second. Is signs and stimulus use disorder? Yeah, no. So that's what this is. So after I apologize. So after I had kind of gone through and summarized, right, amphetamines and the synthetic cathinones and methamphetamine and cocaine in terms of kind of what happens, this table is also here. So some of it's redundant, but not everything. So I'll come back to that in a second just to kind of summarize. But let's take a look at table 6.5. Okay. So if we go back to our Pearson, oh no, we got it here. Okay. And we go to our table 6.5 just to take a look at what is there. Make sure I don't miss it. Okay. Yeah, so again, I think it's worth taking a look here to, take a look at the signs and symptoms that you see in stimulus use disorder. So, this is going to, on the left-hand side, right, systems, concepts that are affected, okay? This is amphetamine, right, methamphetamine, and cocaine, okay? So you can see the different symptoms that you have with each one of these different types of stimulants, okay? Showing you some renal symptoms, fluid and electrolyte balance, neurologic symptoms, right, mood and affect. So there's a pretty long list here of different symptoms that you'll see with stimulant use, okay? So obviously it's all increases, right? Increase tachycardia, right? Hypertension. All right, so if we move down here, seizures are a big thing with stimulants, right? Why? When we think of a stimulant, it's going to sort of speed up or enhance the activity. And if you think about enhancing the activity of neurons in your brain too much, it leads to a seizure, right? A seizure is this increase in activity, in electrical activity, okay? And so these obviously, if enough is taken and somebody has a predisposition for something like that, they can trigger seizures, okay? All right, so again, I'm just kind of scrolling through so you guys can take a look. All right, so there are a lot of sort of signs and symptoms that are listed here. Again, don't memorize them, but I wanted you guys to just be familiar with them, okay? All right. So like I said, some of this, what's here on this slide is redundant from the last slide. All of these, I mean, anything that's going to have a psychoactive effect crosses the blood-brain barrier. So I'm not really sure. So I don't know that it's something different with these stimulants here. I think the idea is that these, the amphetamines and methamphetamine, readily cross that blood-brain barrier. And what you sometimes do see with some of these other psychoactive drugs is that they'll get metabolized first in the periphery, and then that metabolite actually crosses the blood-brain barrier. Okay. I don't want to get too much into it, but the reason why we're sort of pointing it out here is that these compounds themselves can readily cross, and so that leads to a quicker onset of action. Okay, and that's mentioned here. Okay, I think I mentioned almost all of this already. Okay, in terms of treatment, right? There are medications, counseling, inpatient, residential, outpatient treatments. A lot of times those types of treatments are necessary when we're talking about a stimulant use disorder. Obviously, peer support. There's also other more in-depth 12-step programs to help with this type of addiction. Okay. Hallucinogen use disorder. Okay, so these are going to be drugs that elicit hallucinations. Okay, when you think about a hallucination, right, or hallucinogen, I can't even say that. They will alter sensory perception. They'll alter mood, and they will alter thought patterns. But when you think about a hallucination, it's this sort of sensory information that's there without any sort of stimulus, right? So some examples of hallucinogens, okay, are listed here. So we've probably heard of mushrooms before, peyote, mescaline, okay, LSD. These are all examples of hallucinogens, okay, MDMA. In terms of interaction, again, it's mostly the same neurotransmitters we've been talking about. Here, we're going to bring in sort of glutamate, right? So they appear to be involved in, if we're kind of just talking about them in general, interacting with serotonin, with dopamine, and also with glutamate. Remember, glutamate is that excitatory neurotransmitter, okay? And again, when you talk about hallucinations, what are they? They're sensory perceptions that you see, hear, whatever, without external stimulation, right? So they're sort of created internally, okay? Sometimes you call them trip or a flashback or something like that. That's the way that they're experienced, these hallucinations. If we look at some of the signs and symptoms, right? If we're talking about hallucinogen intoxication, again, these are probably things that you would probably need to be able to recognize, right, in the clinical setting, okay? Again, for cardiovascular signs, okay, tachycardia, palpitations, okay, hypertension, could also lead to hypotension, but basically changes in cardiovascular signs, tremors, hyperreflexia, okay? For mood, cognition, and emotions, a bunch of things are listed here that you guys can kind of take a look at, okay? In terms of diagnosis, okay, if you're talking about, taking one of these types of drugs that will elicit hallucinations, right, or these flashbacks, after stopping with these drugs, often these flashbacks will dissipate with time, okay? However, there is a particular disorder called hallucinogen persisting perception disorder, where basically you're still going to get these flashbacks and these hallucinations even after you've stopped that, okay? And they'll just occur randomly without any warning, and basically they'll interfere with daily activities, right? And also, I'm sure elicit a lot of anxiety, right? Because you don't know when these things might happen, okay? In terms of medications to treat, there are no approved medications. It's behavioral therapy and counseling. Okay. I believe this is the last one we're going to talk about. Yes. The last one we're going to talk about is opioid use disorder. And obviously, opioid abuse is a huge problem, right? A huge issue. And so, we could probably spend more time talking about it than we are, but definitely something that we all need to be aware of. Okay. So when we think about opioids in general, it says here their chemical structure is similar to alkaloids found in opium poppies. In fact, things like morphine are derived from a poppy, right? So is opium. And so there are natural opiates, right? And there are also a lot of synthetic opioids out there, or opiates. Their main sort of purpose is to act as an analgesic, right? They're prescribed to alleviate pain. However, they are highly addictive, right? So they are really good at alleviating pain, right? But unfortunately, they are highly, highly addictive. There are 3 main opioid receptors that exist in the body, right? In the brain, but also in the periphery as well, mu, kappa, and delta. And so if you think about opiates like morphine, right? Morphine will primarily bind to the mu receptor, okay? And there are other opiates. Heroin is an example as well. There are lots and lots of synthetic opiates out there as well. So I think I do list some examples on the next slide. If we're talking about opioid use disorder, okay, chronic, relapsing illness of a pattern of opioid use, and obviously it's usually associated with negative health consequences, okay? So like I said, in terms of some different types, right, I mentioned morphine, codeine. Those are naturally occurring. They're derived from that poppy plant. Semi-synthetic, right? Examples are heroin, hydrocodone, oxycodone. Those are semi-synthetic. And then synthetic, things like fentanyl, nasty, right? Fentanyl is very, very potent, okay? And so that's a huge, I think actually the sort of abuse of fentanyl is something that I think that sort of increased over the last couple of years, and it's super, super dangerous. Okay, so there's various routes of administration. Again, they are potent analgesics. They are inhibitory, so they have depressive effects, okay? They can produce euphoria. Again, they are highly, highly addictive. And they're highly addictive. You also develop dependence and tolerance very, very quickly, okay? So that, again, we think about that idea of tolerance, right, is that you need, if we're going to talk about heroin, right, you're going to need to take much more heroin to elicit that same effect, that feeling of euphoria that you're looking for, as you did, say, a month ago, okay? And then obviously withdrawal, there are pretty serious withdrawal symptoms as well. So it says they cause substantial morbidity and mortality, right? There are countless numbers of overdoses that have occurred that obviously lead to death, okay? And again, why? Because these are inhibitory and they will suppress respiratory rate so far that it can lead to death, okay? So if you think about sort of clinical manifestations, I kind of just mentioned some of this, of opioid toxicity, right? decreased vital signs. So heart rate is decreased, blood pressure is severely decreased, respiratory rate is decreased. If these things decrease enough, you're not going to be able to, survive. Decreased bowel sounds, even just sedation or coma, can also lead to seizures as well. If you're looking for, a sign, you can look at this excessive constriction of the pupil, right? Because again, of this depressive, inhibitory effects of, large amounts of an opiate. Okay. Obviously, other signs, you look for track marks if it's injected, right, for heroin, but other types as well. Also, you can snort heroin too, and some of these other opiates. I'm sure we're all familiar with Narcan. We've probably heard of that. Narcan is naloxone. And what is naloxone? It's an opioid antagonist. So what do we mean by antagonist? It will bind to these opiate receptors and block them. And so basically it can reverse the effects of an opioid overdose if it's given in time, right? On time. So, paramedics or whatever carry Narcan with them, right? It's important that you give that as soon as possible to reverse those effects. If not, likely it will lead to death. In terms of, so we have to be careful, right, as clinicians in terms of how we prescribe this or how much we prescribe this. So this is just giving you some example or some information on CDC's prescribing recommendations, right? So your first line for chronic pain should be non-opioid therapy, right? Opioids should only be prescribed when, the benefits of that opiate outweigh the risks, i.e. the risks of addiction. Okay. And if you're going to have to do that, you're going to prescribe at the lowest effective dose, and you're really going to check in on that patient. Okay. To make sure they're not becoming, dependent on the opiate. Okay. In terms of treatment for opioid use, it says medication assisted treatment, buprenorphine or methadone, right? So for heroin addicts, one of the ways that we try to wean heroin addicts off of heroin is by giving them methadone, which is another opiate. But, and so there are methadone maintenance programs, okay, that exist. And I mean, at the Veterans Hospital in East Orange, there's a very large methadone, clinic. And unfortunately, there are a lot of veterans that are dependent on opiates. And so they basically need to be on methadone pretty much for most of their lives in order to be able to function, daily. Okay. And that finally ends chapter 6. So thanks, guys. Let me hopefully find the stop button. Wait, 1 second. I don't know why I have a lot of technical difficulties lately.